When we have to discharge patients that either have improved or are on this long plateau, or that we feel as physicians have a longer prognosis than 6 months or less, we don't want them to feel like they've been abandoned. They've had hospice for 6, 7, 8 months, and now we don't want them to feel like they're abandoned and they have nothing. There are, again, in our healthcare systems, not a lot of programs out there for these individuals. Talking about this hole that there is for care for patients that no longer qualify, graduate from hospice, are not quite at that 6 month or less prognosis, we came up with a private pay program that we call Care Dimensions that involves basically a scaled down version of the hospice model. They have access to 24/7 nursing through the organization. The biggest advantage to this is these people felt like they still had that support of the 24/7. They had somebody who could call, who understood their goals of care and was going to help them keep their loved one out of the hospital, out of calling 911. The U-shaped curve is actually a Medicare, they came up with it. CMS put a work group together. So that's actually one of their ideas for payment reform. So say if you get $100 at the beginning for every day, then it might go down to $40. And then towards the end of their stay, they would go back up to, say, $100. So in that sense, it's a U-shape. What the U-shape model tries to take into account is that the beginning period that patients are on hospice is a lot more intensive. After a little while, things are a little more stable and they need less visits. So the idea is that you pay the hospice less. Then as people get closer to the end, they start to have more symptoms, more crisis. The family needs more support.
We would hope that a change to that payment would take some of the pressures off of discharging patients from hospice because they're stabilized, and we'd be able to provide that care and that umbrella in case things were going wrong, and 24/7 support.
I'd like the hospice benefit to be extended. I'd like to see better payments for the interdisciplinary team approach, whether it's palliative care or hospice.
We're not going to get there without fundamental policy change. And we're not going to get fundamental policy change without political pressure. I think part of the reason that there's been so little attention to it is it's sort of like mental illness. It's stigmatized. It's embarrassing. It's terrifying. So let's just pretend it's not there. And the result is we have a chronic disease, Alzheimer's disease, which from beginning to end can be 15 years or longer, depending on the quality of personal care that people get. That costs more than heart disease and cancer combined by a factor of 2, and yet you see almost no coverage in the popular media, certainly on social media, because it's not a young person's problem, and really very little attention at the policymaker level. So you get policy change if you have a very high level of public demand, and persistent and consistent over time public demand, and effective coalitions and organizations that speak together with one voice on the Hill and also in the executive branch. And the problem with Alzheimer's disease is that the people who are living with it can't advocate for themselves, and their family members are fried. So you don't have, like you had with ACT UP or breast cancer, you don't have flocks of people sitting in their senators and congresspeople's office insisting on action, because they can't. And I don't see the political will that needs to be there to fix it. We're going to need somebody really famous, like a movie star or a president or somebody who gets the public's attention to have to deal with this illness and to do it in the public eye in order to get enough public opinion pressure on policymakers to make the change that we need.